Evening, everyone. President Urological Society of India, Professor Anand Kumar, Chairman Indian School of Urology, Dr. Rajiv Sood, Co-Chairman Indian School of Urology, Dr. Arun Chawla, past presidents of Urological Society of India, senior members of USI, dear residents. Today we are having an important webinar. This is the Residents Forum, and they are the budding urologists. And today the convener, Shah, has compiled a very interesting program, which will be interesting not only for the residents as well as all of us. And it will be a treat to hear our budding urologists speak before the thing. We have expert panel, none other than one of the senior most urologists and past president of USI, Professor Roy Chari, and another senior member from Urological Society, Dr. Shivaji Basu, Professor S.K. Singh, and Professor Sujata Patwardhan as the experts for this webinar. With these good words, I welcome you all once again and wish you all the best. Now I would request Professor Anand Kumar, President, Urological Society of India, to say a few words. Over to you, sir.
Good evening and welcome to this Resident Forum webinar. I bring greetings from the Urology Society of India, and I also like to welcome our very senior teacher, Dr. Rayachali, Dr. Basu, and all the senior members of USI, dear friends and colleagues. Actually, residents are our strength, and residents are our strength. And this is also very important that their training is it has to be a very systematic way and in such a way that they come out with a very good urologist, because we will be in that training period during residency. We lay their foundation, and on that foundation they build their career. And so actually it is unfortunately in our country the resident training program is not uniform throughout the country. Somewhere it is par excellent, somewhere it is lacking, somewhere it is lacking in some subspecialty. And it is very desirable to have a uniform training program and proper structured residency program everywhere, and it should be monitored and should be strictly followed. So that will sow the seed for the very bright urologist coming up for the future, and the urology society will have great future. But a lot of work is being done and a lot more to be done. And we know that regulatory authority of our country is not as strong as in the West, and that's why that part is lacking. But things are changing, and I'm very hopeful that proper changes will come and things will improve. And here, this is a great forum to hear from the residents and hear from the great teachers and very senior members of the society who have trained hundreds of residents, shaped their career, even after their residency, help them in developing their career in different ways, either in private practice or in a teaching institution or in the various other countries. And because of these teachers' help and their good work, they have achieved great success in their career. So in this forum, we'll be discussing various aspects of the training program from the residents, their perspective, and the teacher's perspective. And I hope all these things will help us in shaping the new program in future. And with this, I would like to pray the good health of all the members of USI. Be safe, take care of yourselves, and welcome back to this wonderful webinar. Thank you.
Sir, you are mute, sir.
Now I would thank you, sir, for your enlightening words. Now I would request Professor Rajiv Sood, Chairman, Indian School of Urology, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv TP. Today's webinar and studied with the star faculty and those who are the teachers and teachers of teachers. Dr. Roy Chelly is also with us, and so many people, and this is being convened and conceptualized basically in the resident program to understand what exactly we want and in which direction we are heading. And what is residency? In the residency, which was started in India in 70s, the whole scheme was formalized, and after that, it was implemented, and time to time it was modified. But we have seen the evolution of residency in India, and also working hours, how the residents complained that they are getting drained, and that those problems were also solved, number of hours were fixed, and so many things happening. In the meantime, education became important important of didactic lectures, and the hands-on workshops for our urologists or technical disciplines, especially urology, where technology is integrated. Whole thing is changing. National Medical uh, Commission has been set up, and 2019 onward, the education has become competency based. The grading of the education system has been done all over the world, and the countries have been given the ranks according to the understanding, learning, and other procedures. And therefore, in MBBS, I was the dean of new college. I was the founder dean, and there it was implemented right from the day one. This is competency based education or learning or research or the specialization or the super specialization. What is that? It is the 5 steps. First is the knowledge, know, and the second competency is know how. The third is show, and the fourth is the show how. That is our now Euromet programs and all the workshops, and all we are doing. And then the final is performance. Performance, earlier we were doing observerships, and now it is hands-on experience. First on in the simulators. After that, it is in the wet labs, then animal labs, and then it is on the cadaveric labs, and also then finally we go to the actual performance. So this 5 level of competency and education uniform, which will give us a ranking in the world, has been started in MBBS 2 years back already. The students who are under that are already in second year, and they are now promoting gradually, and every year there is a training of the students, there is a training of the faculty, and also training of the administrators. As dean also, I have undergone twice training for that. And then what will happen in the internship? We had several workshops in ICMR, and for internship, the competency based training has been defined. We have already prepared the modules and identified certain medical situations and how they are going to be implemented. And finally, it is very near future coming to the PG teaching, learning, and also it is coming to the super specialization or postdoctorate like us. We have DNBs, we have MCH, we have several fellowships, but the uniformity will come when we can compete and get good rank amongst the all the global ranking, where you know that Indonesia, Malaysia are very lowly ranked, and we are also not in a very comfortable position. So therefore, this program is unique program. This program, we are going to deliberate on all the aspects of the residency, training and learning, and why the globalization is important, and how it is to be done, and what is the personal experience of age-old teachers and new teachers, and also the expectations of the residents. Let us deliberate on these topics. Let us go further in this webinar, and this is being now going to be convened by Milap Shah, and I am sure that we are going to come to very fruitful discussion and also conclusions for paving our way for the future. Thank you.
Thank you, sir, for your kind words and enlightenment. Now, I would request Dr. Milap Shah, the convener, to give a brief overview and carry forward with the program. Over to you, Milap.
Thank you, sir. Thank you. Good evening, everyone. On behalf of all the speakers, colleagues, and myself, I would like to thank Dr. Anant Kumar, sir, President, Urological Society of India, Dr. Rajiv TP, sir, Honorary Secretary, Urological Society of India, Dr. Rajiv Sood, sir, Chairman, Indian School of Urology, and Professor Arun Chawla, sir, Co-Chairman, Indian School of Urology, for giving us this opportunity. Like always, USI has made sure that residents are at the center of all the activities that they conduct, and this residents forum is just reflects that. And thank you for allowing us to share our views and opinions in various topics, though not academic, but still are important from training and the structure point of view. Giving a brief overview of the entire webinar, we have 10 speakers divided into 2 sessions, 5 speakers in each session. In the first session, we have Dr. Durga Shanti from AINU Hyderabad, Dr. Aita Gupta from Yashoda Hospital Sikandrabad, Dr. Krunal from KIMS Trivandrum, Dr. Nikita from AIMS Jodhpur, Dr. Ravi Tawari from KMC Manipal. And in the second session, we have Dr. Manar Singh Rajput from Dispur Hospital, Guwahati, Dr. Shalabh Agarwal from KMC Mangalore, Dr. Aditya Parikh from MPUH Nadiyad, Dr. Juhil Nanavati from Gangaram Hospital, Delhi, and Dr. M. Sitaram from KMC Manipal. So now I'd like to ask Dr. Aditya Gupta to give a brief introduction regarding our expert panelists, and then we can start the first session with the first speaker. Aditya, can you share your screen, please?
Yeah. Thank you, Milap. I'll just share the screen. Yeah. So can you see the screen?
Yeah, we can see Aditya.
Yeah. So thank you, Dr. Milap. Good evening, everyone. I'm Dr. Aditya, and today I have the pleasure to introduce our experts, though they need no formal introduction. Just hold on. Yeah. So our first expert is Professor Dr. Roy Shelley. Professor Roy Shelley is one of the senior most urologists of our country. He has been instrumental in developing the field of urology in southern India. In 1985, he performed the first renal transplant in Kerala. He is a teacher to many generations of urologists, and his students are now heading urology departments in several centers across India. In his career, he had a long stint as the head of the Department of Urology at Government Medical College, Kozhikode, and the department had reached newer heights under his able leadership. He has decorated the position of Secretary and the President of the Urology Society of India. He is also the member of Editorial Board of Indian Journal of Urology. Our next expert, Dr. Shivaji Basu. He is the Director and the Head of Urology and Kidney Transplant Department at Fortis Hospital, Kolkata. He is the pioneer of PCNL and RIRS in Eastern India. He took the initiative to start transplant services in his part of the country. His main interest is in stone management and uro-oncology. He has authored numerous articles in leading medical journals and presented papers in several national conferences. Our next expert is Professor Dr. S.K. Singh, sir. He is the professor and head of urology department of the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. Though he dazzles in all aspects of urology, his predominant interest is in endourological stone management, uro-onco, and reconstructive urology. Besides being an astute clinician, he is also a world-renowned research scientist in the field of urology. He has innumerable research publications to his name, and his latest being on autophagy in bladder cancer is published in the prestigious Lancet journal. Our final expert is Dr. Sujata Patwardhan, ma'am. She is the head of the Department of Urology at KM Hospitals, Mumbai. Her predominant interest is in renal transplant. She is now the director of ROTO, which is the Regional Organ and Tissue Transplant Organization. She has done more than 200 transplants. She is the team leader of the first adult swab transplant and also the first pediatric swab transplant in a public hospital in India. Besides transplantation, she has special interests in reconstructive surgeries, including female uro and uro-oncology. So these are our experts for today. And now I would like to start our session one. With this, the first speaker, Dr. Durga Shanti Lakshmi, will be speaking about MCH versus DNB. Does the degree really matter? Over to you, Dr. Durga Shanti. Dr. Durga Shanti, please.
Good evening, sir. I'm Dr. Shanti from Asian Institute of Neurology and Urology. And my topic for today is DNB versus MCH. Does it really matter? So after multiple hurdles, we have come to the level of super specialty. We're at the crossroads and have to choose between MCH and DNB. So once we've come to this level, and you start taking opinions from different people, then you start inquiring and what people actually assume. So some of them are of an opinion that is, they have a question as in if DNB is a diploma, didn't you get MCH? Some people are of opinion that every institute has its pros and cons. But what runs in the resident's mind is what is the hands-on experience going to be? How the training program is going to be like? Will I be able to pass the examination? And what will the job opportunities be later on? So there's a study on urology residency in India, which was given by Ganesh Gopal Krishnan, sir. It is a status report giving a SWOT analysis. The strength of the urology residency in India was highlighted to be the enthusiastic urology resident. The urology super specialty is a dream of many general surgery for various reasons and is one of the most competitive super specialty branches. So that gives us a committed workforce of residents who are knowledgeable, keen to learn and improve. The weaknesses of urology residency being no institute can offer everything. Absence of subspecialties in institutes. And research work is another weakness of the residency, individual dependent or the place where you're working. If it is a low volume center, that might affect your research work. The opportunities have improved after the introduction of telemedicine. And the threats for urology residency, there are no major threats for urology residency. So this is the article given by Sir in 2009. And now I would like to just give a brief about MCH versus DNB, the past scenario. So previously, the entrance examination for MCH was institute or university based. The DNB had a common entrance examination conducted by the national board. The counseling was also conducted by the university for MCH, and national board conducts the counseling for the DNB. So how was the course in the past? The hands-on were very good for MCH candidates compared to the DNB candidates. So which gave the advantage for MCH candidates and made many people to choose MCH previously. And also the mentor, that is institute dependent. And as MCH was in teaching hospitals, there was a fixed curriculum. So the academics were thought to be better in MCH institutes previously. Coming to the exit examination, candidates have the examination in the home ground, that is in their own institute. And there are usually 2 internals and externals for the examination. So there's a familiar environment and familiar people around when they're appearing for the examination, mainly for the practicals. Whereas NB candidates for the practicals, they need to go to a different institute altogether, different place. And The pass percentages were very less previously, but gradually over years it has been improving. Regarding job opportunities, MCH candidates were picked over the DNB candidates, and DNB candidates were asked for a work experience before they could be recruited into the teaching institutes. Back for the DNB candidate, and that made people to choose and prefer MCH over DNB in the past scenario. Now, I would like to highlight on the current scenario of MCH versus DNB. Regarding the election process, since 2019, there is a common entrance examination that is NEET super specialty conducted for the selection process of MCH and DNB. And the counseling is also a common online national counseling wherein you have to give your options of MCH or DNB, and then you will be allotted the particular institute. This is regarding the selection process. Regarding the course and training in the current scenario, what majorly matters is the institute. What are the factors that basically influence your choice is the mentor, academic program that is being conducted at the institute. So now in DNB, there are institute-based academics, and also we have a uniformity in the academic sessions that is conducted by the national board, which happens every Saturday, once a week. Whereas in MCH, the academics is purely institute dependent. Regarding to the infrastructure, as urology is a technology-driven specialty, so having access and exposure to the advanced equipment is also an important criteria to be considered. That is having a robot, having exposure to minimally invasive surgeries of laparoscopy, getting exposed to the advanced flexible scopes and using the laser for surgeries. So infrastructure is available in some of the DNB institutes as well as some of the central institutes offering MCH, which is not available in some of the institutes. Having infrastructure is not the only thing. Even having access to the infrastructure is also one of the important things. So you need to even assess as to if the access is being given to the infrastructure. Coming to the employment, it is for the DNB candidate, it becomes easy to adapt to private work culture because they've already been exposed to it. And even now some teaching institutes are asking for the experience, work experience to join into the teaching institute. Whereas for an MCH candidate, there is more, there's no experience required to join into a teaching institute. And they might face a little turbulence in the initial period when they happen to join a private sector. MCH institutes have the advantage of having more open surgeries, so more hands-on experience for open surgeries, where the DNB students might be a little lacking behind. Regarding the exit examination, for the MCH candidate, the examination is at the same institute having internals, so it is a familiar environment in a familiar place that is like a home ground. Whereas for the DNB candidate, it is in a different institute, and all the examiners are new to the candidate. So there is a little of fear factor even now for people who think about in terms of DNB or MCH. And the pass percentages gradually have been improving over year for DNB. Regarding the future, after you have done your residency, you can either choose to join a fellowship or start your own private practice or join teaching hospitals or improvise your skills, that is continue to work under the guidance of a mentor. This is purely candidate dependent. But what exactly is the first thing that people assess once you come out of is first your resume and how your research work is. So it is all candidate dependent. And regarding teaching hospitals, there is more opportunity as the faculty is less. the opportunity to join teaching hospitals has been increasing. So what are the factors that you need to consider to choose any institute? So it is basically you need to choose the institute and not after the degree as to DNB or MCH. The things that you need to consider are you should have a good mentor. There should be good infrastructure with access to it. And there should be a good training program and a high volume center. The training program includes your mentor, the willingness for him to teach, and also the academics that are being carried out. So once all of these are there, let it be DNB or MCH. Once you have all these factors, you will come out as a good urology resident. So suppose you have an option of DNB at a good institute versus MCH. Just because it is MCH, you don't have to run behind the degree. You can choose DNB at a good institute and become a better urologist comparatively. So does it really matter if you're doing it from an MCH or DNB? Perhaps no. So what really matters? So what exactly matters is an enthusiastic urology resident. The willingness of the urology resident, the zeal for him to learn, his capability to grasp things from his mentor and the things going on around him is what really matters. And what should the qualities of the resident be? The resident should be committed. He should have the capability to observe and grasp things as and when the things are going on. And the most important thing is the resident should have the zeal to learn, improve, and excel. So are all residents the same? No, the capabilities of each person differs, and that is what is going to make the difference at the end. So finally, there has to be a balance between, you need to choose a good institute offering the three things that I've been emphasizing on: a good mentor, good infrastructure, high volume center, and the qualities of resident being committed and the zeal to learn, improve, and excel. Striking a balance on all of this helps you to come out as a very good urologist. Thank you.
Thank you, Dr. Shanti, for the wonderful presentation. Next, we have Dr. Aditya Gupta talking on structured program in residency. Should it be made uniform and mandatory? And he'll share his honest opinions regarding the same. Aditya, if you could share your slides, please.
Yes. Yes, so my slides are visible?
Yeah.
Yes, yeah. So good evening, I'm Dr. Aditya Gupta, a final year urology resident at Yashoda Hospitals, Telangana. So my topic is structured program in residency. Should it be made uniform and compulsory? So there are no conflicts of interest. No institutes or individuals are named during this presentation. Now, at the start, I would like to start with a quote. Everyone wants to ride the train, but no one wants to lay the tracks. In India particularly, everyone knows that a structured residency program is the need of an hour because of such a big country. So, but is it implemented throughout the country? Well, let's see. So why is it important? Why is a structured residency program important in any country? The financial resources and the patient load is always limited. The residents need maximum benefit from limited resources. Hence, there is a strong requirement for institutions to develop curricula and their mode of instruction in a manner that is evidence-based. Now, why is this particularly important in India? India is a very large country. There's variable incidence of urological cases throughout the country. It is different in different states. For example, the western part of our country is well known to have a lot of stone cases. The southern part, a lot of cancer cases. So because of the non-uniformity of cases and their exposure, it leads to a non-confident resident. A resident, particularly in a western part of country, might have not faced such large number of oncological cases, and vice versa. Also, there are economic differences between different states, between different institutes of the same states. For example, an institute might have all the financial needs, and there might be robots, the latest technologies, latest lasers, RIRS, and others. Whereas a peripheral institute might be doing all the surgeries still in an open manner or like thereof. So as a result, there is inadequate exposure of the resident and there's a doubtful surgeon. So what is the answer? The answer is a structured residency program. Now, what is it actually? Training of a new resident through a systematically developed education program. It has a clearly detailed schedule. There's the time frame. There's outline of activities per resident per year. Assignments of responsibilities according to the year. There's well-defined goals and consequences. This leads to more success and development than an unstructured program. The advantages. The goals are stated clearly. There is certainty. Now, to become a urology resident, you need to pass your MBBS, you need to pass your MS exam, you have to give your super specialty, you need to score good, and then you get a urological resident seat. So, with all these exams, we need a certainty. In most of our countries, the cases exposure is dependent on the whims of our senior residents. Now, if there's a structured residency program, the first years know that they will get these surgeries or they are going to get such exposure. That similarly, the second and the third year, so there's a certainty in their mind. There's clarity, consistency, measured outcomes, follow-up, and motivation. Structured program helps the students to know what is expected of them and makes them more accountable. It also helps the authorities to judge the completeness of the residency program. Now, this is an example of an unstructured program. Now, this is a jigsaw puzzle. You do not know what it is at the end, how it is going to look like. You do not know whether there are any pieces missing. Now, with trial, with time and trial, ultimately you're going to finish this, but it is unnecessarily waste of time and resources. What if I showed you this at the start? You know at least that what you're expected to make. You know that all the pieces are still there. And so this will be helpful. This will be easier for you to start the puzzle and to complete it. This is what a structured program generally is. So structured training has been found to be beneficial in the development of cognition, psychomotor skills, and the effect of students in the skill set. It has been found to improve the clinical skills, knowledge, and attitude in different groups of students. So how does an ideal structural program looks like? There's a goal. Yes, obviously, the making a confident and a competitive surgeon. Objectives that at the end of the course, the resident will be able to do confidently these surgeries. He'll be able to assist these surgeries, and he'll be able to he can face such patients. It should also include the teaching and the training activities and their frequency. For example, case presentations, whatever might be once or twice a week, seminars, journal clubs. Now, this is particularly important. Particularly in urology, there are newer inventions coming every year. Now, the textbooks which are made are 3 to 4 years. It takes 3 to 4 years for them to get published. Within that span of time, more inventions have come. There are disease management strategies have changed. So to remain at par with the world, this journal club is quite important. Ward rounds, faculty lectures, audit. Actually, this ideal structural program is like a blueprint. Now, if you want to make a house, you don't directly go, you get bricks or a log of wood and make a house. It will ultimately lead to something like this. If you want to make a good house, what you need is this. This is the blueprint. You go to an architect, you get your blueprint done, you get to know the dimensions, the materials which are required, the quantity, and finally, you'll be able to make a sturdy home. So the surgeries and case differentiations according to the residency year. Now, my professor, he told me one thing that during his residency, I'm just giving you an example of what he told, was that first years, the stone patients were managed by the first years. The final years had to manage cancer patients. So after emergency OPD, when the patients got admitted, the onco patients were the total responsibility of the final years, right from their case history, from their CT-all, intra-op, pre-op, intra-op, post-op, and follow-up was all managed by the final year residents. The first years did not take a role, they just observed. So this responsibility according to the residency year is very important. Step-up approach to complex cases. interdisciplinary postings. Now, as a urologist, we need a certain amount of knowledge for our nephrologist, from pathologist, and from radiologist. So a posting for certain weeks might be a good option. Exchange programs. As already discussed earlier, the various parts of the country cater to different case scenarios, different case loads. So a resident from one part of the country might be very confident in a particular set of urological cases, while he might not be so confident in another set. So India being such a large country, they get cases everywhere. So exchange programs might be a good answer. So in the end, I'd like to conclude that a uniform structured residency program is the need of the hour in our country. Initially, teaching institutes were limited and they had experienced teachers who had time and tested residency programs. Nowadays, new institutes are opening. With the shortage of experienced teachers and their guidance, everyone, including the students and the teachers, are facing a problem. Structured residency program will help both the student and the teacher to know their strengths and shortcomings and accordingly find a way out. Thank you.
Thank you, Dr. Aditya, for your honest opinions and views. Next, we have Dr. Krunal Rathod from KIMS Trivandrum talking about burnout during residency program and how to bounce back. Dr. Krunal,
Yeah.
if you could share your slides, please.
Yeah, sure. Yeah, so is it visible? Hello? Yeah, is it visible? Yeah.
Yeah, it is visible. Krunal.
You're audible.
Yeah. Good evening, respected teachers. I'm Dr. Krunal Rathod. I'm going to talk on this burnout during residency program. So basically, this burnout is a part of the mental health, which was introduced by psychologist Herbert Freudenberger in 1974. Actually, it was basically described for occupational worker. Subsequently, in 1997, Christina Meslach has defined this term and popularized it. She has given Meslach burnout inventory, which is most commonly used nowadays to measure the burnout. This inventory is subsequently used in residency program as well as practicing physicians also. So basically, burnout is a syndrome of depersonalization, emotional exhaustion, as well as low personal accomplishment. So all these three lead to decreased effectiveness at work. So basically, these three were the main component of this Meslach burnout inventory. So according to our national survey, this 56.6% of residents are being burnout. This 54% of residents was having this emotional exhaustion. 40% of residents is having the depersonalization issue. So out of this residents, only 10 to 12% of residents only represented to psychiatrists for the health. So this is actually issue in India. Basically, all this there is a stigma in India that this mental ill health means they will think like it's mental retardation, or like we called in Hindi like pagal and all. But actually, basically, it's not like that. You have to accept your mental health. You have to consider it, and you have to ask for the help. So this is the maximum seen in resident with high working hour per week, like critical care residents, general surgery residents, etc. So more common in young resident, more common in female, more common during the first year of residency, and more common in singles rather than married. So according to national survey, this is the actually graph showing a percentage of burnout in different subspecialty. Urology being somewhere in middle lower part of this graph. So yeah, I also did my survey. I did little survey. I carried out one surveys amongst this around Institute of Kerala. So my in my survey, actually 113 people participated, resident basically, and that survey report showed 50.6% of resident was having the sign symptoms of burnout. 50.4% was showing the depersonalization, and 47 residents was having reduction in personal achievement. Basically, the study for the particular urology residency program is a lake in India. So I could find one article of USA which state urology is one of US's most burnout branch, which is worsened over 20% in past 3 years. Most common reason being excessive working hour. So average incidence being 47 to 54%. So this is the actually currently issued article in Indian Journal of Urology, which showed the impact of COVID-19 pandemic in urology residency. Basically, they conducted nationwide survey. In this survey, also 2/3 of respondents showed the sign symptoms of burnout, which is related to COVID-19 restrictions, fear of infecting the family, etc. So why burnout? Why it happened? So it happened due to excessive workload, excessive working hour, clerical burden, complex patient-related decisions, inefficient environment, inadequate support away from the family and friends, inadequate leaves to visit the loved one, inadequate sleep, and irregular meals. So no time they allotted for the recreational activity and loss of autonomy. So all this burnout related stress will cause sympathetic nerve signals to adrenal medulla. This adrenal medulla release catecholamines into the bloodstream, which give rise to fight or flight response, which gives rise to physical consequences as well as psychological consequences. So physical consequences include obesity, dyslipidemia, diabetes, hypertension, cardiovascular disorders, cerebrovascular accident, as well as mortality below 45 years. So psychological consequences include insomnia, depression, anxiety disorder, bipolar disorder, and so on. So basically, this all the consequences lead to error in decision making, diagnosis, and treatment of the patient, which leads to impaired professionalism, reduced patient satisfaction. So this all burnout leads to interpersonal relationship also, which affect interpersonal relationship between family and friends. So this burnout related consequences will lead to increased incidence of motor vehicle crashes and near misses, as well as the incidence is increasing. The problem is substance abuse. This current situation, this suicidal ideation and suicide is actually current scenario. It is a worrisome problem for us. According to survey, 15% of worldwide suicide happens in India. So which is very surprising and unfortunate. So nowadays we have witnessed so many cases of suicide. So this is actually a worrisome problem. So we have to be very protective regarding that. So now how to bounce back from burnout? So we have preventive strategy and therapeutic strategy. So in the preventive strategy, we can increase the work engagement, mentoring program, opportunity for research, promoting positive work environment, as well as building the resilience. So what is resilience? It is the ability to bounce back or recover from the stress. So which consists of 4 main aspects: positive attitude and perspective to work, work balance and prioritization, good practice management styles, and supportive relationship. So don't say I can't do, always say I can do. According to Accreditation Council for Graduate Medical Education in 2003, they introduced one following reform for resident program, which actually formed for the to tackle the burnout situation. So they suggested 80 hours per week, 10 hours of rest in between duty periods, 24-hour limit on continuous duty, 6 extra hours for education and continuity of care, 1 day off every 7 days, in-house call no more than once every 3 nights, average over 4 weeks. So what are the therapeutic strategy? So in general, one should attend the conference. They should participate in group discussion. They should feel free to contact the professional body to deal with burnout. Even talk it out with your colleagues, your mentor, your family, or friends. So you engage yourself in reflecting, writing, music, medication, yoga, physical exercise, have spending some quality time with your family, or you can engage yourself in your favorite sport. In USA, actually, to fight this situation or to prevent this burnout situation in residency program, they have stress management program. According to this program, they have to allot 6 hours per month for this such kind of program, as well as they have to attend booster session in between. They have to participate in wellness programs also. So I'll stress on this point to my respected teachers that we don't have this kind of program in our residency program. So we could include this in program, or we can just institution wide we have to be some stress management program should be there to tackle with this burnout situation. So what we learn, what are the take-home message? It's okay to ask for the help. So actually, residents have to identify they are burning out, and they have to present themselves to the professional body who tackle with this such kind of situation. Even you can share your feelings with your mentor, your colleagues, your family members also. I could say this because I also went through this situation. So I also took my family members and my mentors' help, and I could say now on this situation. So yeah, it's okay to ask for the help. So I'll conclude my presentation with this beautiful quote by Christina Maslach. If all the knowledge and advice about how to beat burnout could be summed up in one word, that word would be the balance. This balance between giving and getting, balance between stress and calm, balance between work and home. So thank you.
Thank you, Krunal. That was great. Your impactful data on burnout and how to bounce back from it. Next, we have Nikita Srivastav from AIMS Jodhpur talking on female urology resident, the current scenario, and the views from her personal experience. Krunal, you need to stop sharing your screen.
Yeah,
now.
yeah, sure. Yeah, sure. Yeah, okay.
Nikita, can you share your slides?
Yes. Good evening, everyone. Myself, Dr. Nikita Srivastava from AIMS Jodhpur, and I would be speaking on female residents in urology, current scenario, and views from my experience. A 15th century proverb has said, an ideal surgeon to have the mind of Asclepius, the eyes of an eagle, the heart of a lion, and the hands of a woman. Here, the last line doesn't refer to the physical characteristics of woman's hand, rather the temperate nature of them. There has been literary evidence of females performing surgery in ancient times for over 5,000 years, but they were discouraged to be in forefront of medical profession in Middle Ages. The middle of 19th century witnessed the dawn of women entering and graduating from medical schools. Females in surgical specialties were encouraged to be in branches dealing with female patients, like in case of Dr. Anne Brumal, who was one of the first contributors in urology, but later she became a gynecologist. Other earliest female urology trainees were Dr. McGregor, Dr. Schumacher, and Dr. Lespinasse. And the first female board-certified urologist was Dr. Elizabeth Pickett. Amongst notable names in Indian urology, Dr. R. Revati has been a pioneer, but Indian urology suffered a huge loss due to her sudden demise. In 1980, Society of Women in Urology was found with just 5 female members, which rose to more than 300 members in 2008. And in 2019, urology residency match results in US showed a record high of 83% of women applying match to urology residency programs in US. Here is a diagram depicting the rise in females certified by American Board of Urology. And a similar rising trend have been observed in female residents in urology residency programs in US. Though no study till date has been done depicting the proportion of female residents in Indian urology institutes, still for sure there is a similar rising trend in India too. But if we talk about the overall proportion of females in different specialities, urology has lowest number of females, as shown in various studies. In one of the surveys conducted by American Urology Association, globally, over urology residents, there were no female participants from India. And awards given by different urologic societies, in there also only 7.8% of awards were given to females. If we talk about practice profile amongst females in urology, among different urologic subspecialties, maximum number of females choose to pursue urogynecology and a handful of them pursue andrology or sexual medicine. So, why we need to address this gender gap and why we need more female urologists? Globally, we are witnessing the dissolution of patriarchal society and more females in forefront of what were traditionally considered as male-dominating branches, such as defense, legislature, judiciary, or sports. And that's why surgery is not an exception. So there is nothing atypical or path-breaking about females being a urologist, because in the end, what matters is a person's interest and guiding light in life. Commonly found incentives for female pursuing surgical specialties are the nature of the surgical branch, presence of positive role models, and a greater job satisfaction due to rewarding nature of surgical branches. If we look at the chronology of Indian female medical students, about 44.8% of students pursuing MBBS were female, but in the same year, practicing female doctors were just 19%, general surgeons were just 2.5%. So there was no separate study depicting surgical super specialist females in India, but observing this trend, we can just assume the sparse number of them. So what are those factors which negatively affect the participation of women in traditionally male-dominating branches like urology? Women may be deterred by presumed surgical personality and perception of surgery as an old boys club. Also, it is falsely believed that urology mainly comprises of male patients in general terms, which is absolutely wrong, because genitourinary complaints can be of both males and females. Women may also face what is known as implicit bias. Though explicit bias or clear-cut gender discrimination is rare in today's scenario, what women can face can be said as microaggression, which is subtle, often subconscious, discriminatory actions which point towards the demeaning or hostile messages towards female. Because at the end of the day, what a person expects from his or her workplace is acceptance. And when women are not accepted the same way as their male counterparts, they feel distressed and frustrated. In various studies, it has been also shown that in surgical specialties, females are given more of academic and clerical work as compared to their male counterparts and less of operative work. So they are depressed due to that, and also their minute mistakes are also pinpointed and made issue of, which would have been otherwise ignored in their male counterparts. Concerns regarding work-life balance is also an issue which is deterrent for females pursuing demanding branches like urology. In India, it is believed that females should look after the household chores and the males should be the primary breadwinners. So family and society are not so cooperative for females pursuing full-time demanding professions like urology. And sometimes females themselves take a setback and sacrifice their career for raising a family. The opportunity to discuss expectations with someone who has followed the same path is invaluable. And that's why lack of female mentorship is just like absence of a guideline in this road less traveled for females. Being the only female in the room might be a concern for some. And one important perspective is of patients, where most patients prefer same gender urologists because they felt less embarrassed. And that's why more female urologists are also required. Here, I would like to quote a study by Trine et al., which was a systematic review on factors influencing female medical students to pursue surgical specialties. Here also, they have discussed similar negative factors influencing a female's decision to pursue urology. And according to this study, this is the summary of positive and negative factors which influence a female's decision to pursue demanding branches such as urology. Now, as far as my experience in urology is concerned, I am privileged to have a very cordial working environment at my institute and equal academic and operative learning opportunities. There were few incidences of discrimination by patients in OPD and wards, like male patients refusing for examination or passage of some gender-based comments, but they don't matter for me. Being only female in the room has never been a concern for me. And I also have a strong emotional support by my seniors when I feel low, and they help in my academics too. And most importantly, I am blessed to have a strong family support where my parents, husband, and in-laws have always respected my decisions and they support fully in my career. So, to conclude, it is never about gender because the interest, attitude, passion, and ambitions of an individual should be above gender, society, or cultural norms. And a surgeon is not defined by gender. Also, in India, where family takes an upper hand in deciding important life decisions of an individual, daughters should not be considered as a liability and their marriage should not be put in forefront of their career. It is also responsibility of females to not to give up their dreams, and instead of fitting in the glass slipper framed by the society and family, they should rise above, break the glass ceiling over them, and should excel in their careers. So, families should support females in finding a midway balance between their dreams of career and family responsibilities. Also, concrete steps such as ensuring that male and female candidates for a position are judged based on merit and accomplishment rather than on presumed gender stereotypes should be implemented on an individual and immediate basis. And also, a broader commitment to addressing gender bias is also required. More role models and positive reinforcement by colleagues and seniors should be there. And this all should be done because a more equal and diverse workforce will be an asset to the field and patients for generations to come. Thank you.
Thank you, Nikita, for the hard-hitting facts and your sharing your personal experiences. Next, we have Dr. Ravi Tawari talking on role of a mentor during the urology residency.
Is my screen visible?
Yes, Ravi, it is visible.
Yeah. Thank you, USI and ISU, for this opportunity. I am Dr. Ravi Tauri, Registrar, Department of Urology and Renal Transplant, KMC Manipal, and I'll be sharing my views on role of a mentor in residency. The origin of the word mentor lies in Greek mythology. Ulysses went to fight in the Trojan War, and he entrusted the care of his son Telemachus to his older and wiser friend, Mentor. Concept of mentorship dates back to the era of ashrams. Guru remained the lifelong teacher of a particular student. This was the first example of mentoring students under supervision. Who is a mentor? Is he a coach? Is he an advisor? Is he a motivator? Is he the one who supports us when we are down? Or is he a guide? Actually, a mentor plays not one, but all these roles at some point of time. Formally, mentorship can be described as a dynamic, reciprocal relationship in a work environment between an advanced career incumbent, the mentor, and a beginner, protege, or a mentee, aimed at the development of both. Coming to the role of a mentor, by far, imparting surgical skill is the most important role of a mentor. He oversees each step and reevaluates it until it is done right. To succeed in this day and age, building a network is of utmost importance. We can connect to various other doctors through the network of our mentors. It is said that academic success depends on research and publication, and a mentor smoothens out the path towards a successful publication. Mentor also enhances our soft skills. Soft skills are personal attributes needed for success on the job. They can be time management skills, networking, teamwork, creative thinking, or conflict resolution. A mentor who enhances our soft skills also leads to a better patient interaction and invokes trust amongst patients in us as surgeons and doctors. Letter of recommendations also form a huge part of the role of a mentor. After MCH or DNB, a mentor can put a word into the ears of our next program director, which could be a lot of help. A mentor should be available on a regular basis. He should be approachable and non-judgmental. He should show appreciation and he should value our opinion. What a mentee needs to do. We should take initiative. We should recognize the need of mentoring and seek it out. We should accept critique, accept that mistakes will be done and learn from them. We should work hard and be prepared to give it our best. We should support our peers personally and professionally. We should accept that the job does not begin and end into the operating room, and we should take responsibility of the long-term result of patient care. We should maintain work-life balance and preserve time for family and friends. Now, what formal or informal mentorship is? Is formal mentorship program needed or informal mentorship enough? Going through literature, I found these interesting quotes. I relied more on my direct experiences, on my rotations and talking to family members who are physicians because I did not feel like we had mentors in medical school. Another one said, I really had to rely on my friends in residency as my main mentors. I will say that this mentor was sought out by myself at a conference and not through this institution. This institution put in contact with a graduate in my specialty. She greatly assisted me in getting into a program that I matched in. Family members and friends form the part of our informal mentoring group, but these are unstructured sessions. The focus of these relationships vary, often related to the current circumstances. Momentum throughout an informal meeting, mentoring is driven by the strength and connection between the mentor and the mentee, and there is hardly any accountability. In contrast, formal mentoring has a structured framework. It has clearly articulated expectations from the mentees and the mentors. There is a specific time frame and more accountability. Now, what is the current status of mentorship in the West? Mentorship in urology residency programs in United States is an article by Botnick et al. Published in Urology 2019. The objective was to characterize the status of mentorship programs of urology residencies in the US, highlight the importance of mentorship in the career of a urology resident, identify the obstacles of implementing a mentorship program. For this, a survey was sent to the program directors of all the residency programs, urology residency programs in the US. This survey contained questions about the presence and structure of mentorship programs in their department. The results were as follows. 75% of the respondents approved of a formal mentorship program. 58% stated that they had a residency mentorship program already established. In 70% of the mentorship programs, the resident is formally assigned to a specific mentor. 5% of the mentorship programs had official training course for the faculty mentors, and 20% of the mentorship programs had a career development course. The same article also stated the reasons for lack of formal mentorship programs. The major reason being informal mentorship is thought to be sufficient. The other factors in play are not enough time, not enough funding, resources, not enough faculty interest or resident interest. Something about burnout. Dr. Kunal had beautifully outlined burnout in his presentation, but I would just like to state that North et al. In his article on burnout in urology stated that 38% of practicing urologists meet the criteria for burnout. And a survey carried out by Marchalik also stated that 68% of the urology trainees reported some sort of symptoms of burnout. The same author in his paper, The Impact of Institutional Factors on Physician Burnout, also stated that structured mentorship program was associated with decreased burnout, which was statistically significant. Now, coming to the benefits of mentorship, the benefits to the mentee are increase and enhancement in surgical competency, increased academic productivity, a career boost, and a work-life balance can be struck. For the mentor, it increases the research productivity, there is a sort of personal satisfaction, and it opens career advancement options. So I conclude by saying mentorship should reach each and every budding urologist, as patients and society at large are also stakeholders and beneficiaries of this relation. Seldom can one person play all the roles of a mentor, thus collective mentoring should be sought for. Thank you.
Thank you, Ravi. That was a very visually appealing presentation. By this, we come to the end of the first session. Now, may I request Professor Roy Chelly sir and Shivaji Basu sir to share their expert views and comments on the presentation till now, sir. Professor Roy Chelly sir is there.
Yes, excellent presentation by all regiments.
So you have to unmute yourself, Professor Archali. Professor Archali is muted, actually.
Yes.
Yeah.
Okay.
Yes.
That's it.
Okay. Good evening, Shivaji. I think I'll go first. I would like to, at the outset, I would like to thank the USI for inviting me to chair this session. It's a privilege and an honor, and this is a subject which is dear to me also. Coming to the presentations, the presenters, they have done a good job of what they were asked to do. I would like to give a broad view of the subject. There's a scarcity of urologists in the country. The administration wants to fill up this deficit in a quick manner. So what do? They increase the number of trainees under a teacher in medical colleges. They rope in consultants in private hospitals to train the residents. Quality suffers when emphasis is on numbers. Hospitals and public want quality, but unfortunately, they do not have much voice in policy decisions. Now you find that the entrance and the exit examination is conducted by one body. I think it's going to be there in the years to come. So I don't think that there should be a DIP-NB and MCH degree. All could be one degree, I think, whatever the government decides. Hospital insists on a degree for privilege to practice their specialty. You must remember that that privilege can be withdrawn by the hospital if the performance of the urologist is damaging the reputation of the institution. Our bread and butter is dependent upon our performance, which in turn depends upon our knowledge and competence to deliver on our knowledge. A minimum standard for the structured training was brought out. I mean, it's very important. But what is important there in the structured training is there must be a quality control. Objectively, there should be a quality in the quality control in the structured curriculum. And it should be measured objectively, periodically. This is a very essential key step. I think in DIP-NB's national board exams, they are trying to implement that. Again, when it comes to the exit examination, also, I think we need a objective quality parameters to ensure that the urologist is properly trained. I mean, this should be a way in which one could objectively measure the parameters when he is passing the exit examination. The training period, when coming to the burnout thing, the training period is always stressful and grilling. burnout feeling can also come when you lack aptitude. That's a very important thing to remember. This is a time to consider your choice to continue with this training. One must remember that lack of aptitude or lack of zeal to specialize in the particular subject that you have chosen can affect the performance. Coming to the sex and speciality, I think a good case has been brought out that there's no need to make a difference between the male and female. I think the sex should not matter in specialization. What should matter is whether the person has an interest to specialize in the subject. That is there. I think there's no problem with whether male or female takes a specialty. Coming to the mentor, one important point which is missed out by the presenter is that the mentor is always under observation by the training, and one aspect which the mentor has to always remember is that whatever qualities of life he has is actually being observed by the candidate, and chances are that he will try to practice it in the rest of his life if the mentor is not careful about his quality values in life when he is training the candidate. Now, with that, I would leave it to Shivaji to complete.
Right. Well, thank you very much. At the outset, let me first thank USI and ISU for giving us the opportunity to participate in this wonderfully organized program. And the last point I take about the mentorship, unorganized mentorship, there is an example, Roy Shelley being our mentor, which was not a structured mentorship, but that's how you always get mentorship and you get an impetus to work. Well, coming to the discussions, first of all, the quality of presentation of the boys and girls today, that shows what sort of brilliant products we are getting in the urology scenario. That's the strength, as Ganesh said, and we have to utilize that strength. I have not worked in the teaching institutions. We are in the private hospital having the DNB for the last 8 years. So I can talk more about the private hospitals and what are the lacunae there. One must admit that the teaching institutions, wherever in the eastern part, the number of cases and the case mix and the complicated cases, that is much more in those institutions. So the MCH students get an exposure to the variety of cases and the complicated cases, and to hands-on training as well. Whereas the DNB, most of them are in the private sectors, there's not always, in not all institutions, I'm not generalizing it, but a lot of institutions, they do not have that much of case mix. And because of the socio-economic pressure, the hands-on training is not up to date. But things have changed over the last 4 or 5 years, where NB has taken it up, that you have to have so-called structured program as much as you can and go close to the MCH training program. In this issue, I must say that a lot of the private hospitals who had the DNB program, they do not have the facility of residential status to the DNB students. So the postgraduate students, they do not stay in the hospital. They stay outside somewhere, rented accommodations, and they come, certainly they come when they're needed to, but that is not good enough. Because if you do not follow the patients throughout your operation, and we have spent 72 hours in our young days when we didn't go home and we wanted to see the end of the story. So MCA students are privileged in that sort of thing. But mind you, this, I'm not again generalizing it, but that needs to be looked at. The exit exam, the DNB, they have a lot of, on the theory papers, a lot of importance are given. And although things are getting much easier, but even 5, 6 years back, that's a big hurdle. And so, unlike the MCH examination where the theory papers are only counted if you have not done well. So that is comes as your savior. But at DNB, you don't cross the hurdle, you don't appear, although you are a very competent urologist. So that part needs to be addressed. And also at this context, I must say, we have to all rethink about the whole structures, although this is not the forum, we cannot guide, but this 3 years plus 3 years, 3 years general surgery and 3 years urology may not be the right structures. So general surgery exposure is certainly good, but if it's a combined pickup of a structured program where 2 years will be spent in the general surgery, 4 years in the urology, then it will be much better, because by that time you know to come to know your student and come to know their proficiency and their competency. Time is always gone, and you don't have a time to produce papers within this 3 years. So that has to be rethought about the whole thing. And one of the exchange program which you commented was certainly a good idea, because there's a regional variation of the cases mix, and you do not see the stone cases where in the belt, you don't see the oncology cases. So that's a good idea. USI can take part in that thing. Also, what USI can do, the logbook, for the sake of logbook, is not good enough. That logbook has to be maintained properly, and USI should have a predefined logbook and will be supervising whether the logbooks are maintained. And that NB can also do, but it needs help from the USI. Last 2 points I want to mention. One is the yoga session, the burnt out thing. You know, any industry which actually excels, they have got a happy family. Like TCS, they have got a happy family. So unless this is a happy family, your productivity will not go up. So you have to get the productivity at its height. So you have to have a happy family, happy work and ambience, and automatically your burnt out things will be going down. And mentor is obviously plays a huge role in that thing. And last thing is the female participation of ladies here. That obviously one shouldn't, the discrepancy shouldn't be there, but one cannot deny the fact from the population we are dealing, the age group we are dealing in the urology, and a lot of urology, take the female urology apart, they have got a reservation, but it depends on the mentee and it depends on the trainee who have got a zeal and the thing, they will go forward. Nothing can stop them, because I have got non-DNB female registrars. They have really done well, and in fact, the patients prefer them because they talk well. They have got a more recipient attitude. So if you have got a zeal, why not excel yourself? Thank you very much.
Thank you, sir. Thank you for your enlightening views. I think Sujata ma'am wants to also comment on the presentations, ma'am.
Yeah, good evening. And I would like to make 2 or 3 comments. First,
Yes,
regarding the female part, because I am a female, I would like to share my experience, which I don't think has been covered by the speaker. That as a female surgeon, you do face sexual discrimination and certain amount of inappropriate behavior sexually. Though I did not face it in urology, as training as a general surgeon, I did face it. And being a female, I have spoken to many other female surgeons, and this does happen to a certain extent. And another thing about being a female is we during the residency program, you are in your prime age, that is between about 26 to 30, and usually you get married, and many a times you end up in having children. And the long hours spent in urology residency, you do end up in neglecting the family to a small extent or a large extent, depending on whatever your duty hours, but that can't be ruled out. As females, we have to bear children, we have to take responsibility of the family, and this does take a toll, because as men, you don't have to become pregnant. neither do you have to take care of the babies for the next, at least the next 3 months by nursing them regularly. So this does produce a dent in our career because we have to take a break of minimum 3 months to 4 months or sometimes even 6 months after pregnancy. Another point about exchange programs, which you were talking about, that I am also aware that all the DNB hospitals do not cater to all the types of surgeries done. There are certain DNB students who have not seen any urethroplasties at all. But at the same time, I feel that you need to take a feedback, which is very critical, that in spite of having all the things in your city, many of these students don't even take the efforts of attending or taking an extra time on and coming and learning the skills which are there in the. So it is important to say that we want an exchange program, we want to train under different mentors, but the zeal has to come from within you. Because I don't think there is a single teacher who will say that don't attend my surgeries or don't come and learn from me. So this is the feedback I wanted to give back. Thank you.
Yeah, just to make the atmosphere more light, because people have become very serious. Looks like, because next session has to go in a very jubilant mood, as had been the first session. So I will just like to make a comment. Yes, I think as is the gynecology for male, it is the surgery and urology for female, probably. So there's a one program, Tejaswini. It is being shown on DD News every Saturday evening. Please watch how to encourage, how to again overcome the gender bias. So with that light comment, I will just hand it over to Dr. Mila, please.
Thank you, sir. We begin the next session. The first speaker is Dr. Manorsi Rajput from Dispur Hospital, Guwahati. He'll be talking on collaboration among Indian urology residents for research. Is it possible? Manar, your slides are visible. You can start, I think. Manar, you are not audible. You are mute.
Good evening, respected teachers and my colleagues. Thank you, USI and ISU, for the opportunity. I'll be speaking on a collaboration among Indian urology residents for research. So collaboration among researchers can take various forms, and just a minute, it's not okay. And in academic research, collaboration usually means an equal partnership between two or more academic faculty members involved in a research project. So collaboration could vary from initiating a project with colleagues from the same discipline to multidisciplinary collaborations, including collaboration between academic and government institutes or across geographic locations. So the most important aspects in the successful collaboration is trust. There should be an open, honest, and responsible communication between the collaborators. There should be an formal and informal agreements between the collaborators, and in case of funded research, roles and responsibilities of all the collaborators should be mentioned on paper. So then the determination of authorship credit should be according to the contribution of all the authors. And as an individual from a single center in a shorter duration of time, it is not possible to produce high impact research. So collaboration will definitely help in that. There is exchange of ideas and skills between different members, and that will help in enhancing the quality of research and research competencies among the members of the group. And it also allows to produce appropriately powered high impact studies with high number of patients in a shorter time span. So is there any ideal project to begin with? As such, there is no ideal project, but we can start with certain projects which suits well, which works well as initial projects in a collaborative research. So first one is short-term data collection, which can be done during residencies, during the residency by urology trainee, and it can be of 15 days or 1 month, and after that, residents can join clinical duties as well. The commoner the pathology, the faster the patient recruitment and the more number of data we can collect. So begin with common pathologies. Observational studies generally require no funding, and these studies can help in generation of hypothesis and for the future studies. International studies can also be performed between the two institutes, but the important aspect is the collaborator should not have any inclination toward the particular procedure. There should be equal faith in both the procedures of by the collaborator. So are there any research projects going on around the world? Are there any research organizations in the world? Yes, there are. First one is BUS, that is British Urology Researchers in Surgical Training. This was established in 2005, and it is an international research group comprising urology trainees, medical students, surgical trainees, consultants, methodologists, and basic scientists. The aim is to produce high-impact multi-center audit and research which can improve patient care. So at present, they have more than 500 collaborators around the world, and these are certain projects. Certain projects are published by them, and if you are right now, they are working with it. So DTOT and Fixit on orchidopexy, these trials are ongoing. The other are mimic study on role of inflammatory markers in acute ureteric colic, identify trial on suspected urinary tract cancer, and resect trial on evaluation of bladder cancer treatment. So in resect trial, if someone hospital wants to join or wants to collaborate with them, then they should be performing the transurethral resection in non-muscle invasive bladder cancer, and they should submit at least 25 retrospective and 25 prospective cases in a year. So first phase is study registration, then data from the retrospective phase, and then enter the data from prospective phase, and then the follow-up. The second is European Society of Residents in Urology. It was established in 1991 as a body representing the trainees in urological surgery within the European Union and its associated countries. It's a part of Young Urologist Office together with young academic as well as non-academic urologists. And it works in collaboration with European Board of Urology and European Association of Urology. The main objectives of this group are to support the training in urology in Europe, to closely collaborate with other institutes, other groups, to organize congress and workshops for urologists in training, and to support the creation of national associations for urologists in training in Europe and promote research collaboration. So is it possible in India? Yes, it is possible in India. But first, do we have manpower? Do we have institutes? So to begin with the collaboration projects. So these are the data from National Board of Educations. So at present, we have total approximately 387 urological trainees this year in 147 institutes. So if we start collaboration among with these institutes, then there will be another pandemic called database. But there are certain barriers, and those are lack of funding. Second is lack of time during residencies. Residents are barely getting any time for research outside their clinical duties. There is lack of space for the basic research, and the fourth one is mentorship. So how can we start? So first we have to tackle all these hurdles and all these barriers. So first is money. Urological Society of India can make ties with the pharmaceutical companies or government organizations, ICMR, or from the Department of Biotechnology grants, or health insurance firms which will be interested in phase 3 clinical trials. Second hurdle is time. So we should dedicate a few months of residency for basic and clinical research, and the ideal time is during second year. There should be coursework in epidemiology and biostats and ethics, and the certificates should be made mandatory during the training. This is a future floating research lab which can carry almost 7,000 research scientists. But we don't worry, we don't need that. What we need is basic research labs, institutes dedicated for single organ function. The last and most important part is mentorship. Students should be exposed to research and enthusiastic and dedicated mentorship. The role of mentor is to inculcate the ideas in the student's mind. And unless we ask the question why it is not possible, it is not possible to do research, or not possible to generate new things. There should be everyone should take good clinical practice courses. every scholar should be allotted H index, and H index more than 15 should be made mandatory for any mentorship. So if we start in India, what diseases to study? So as we can see in daily clinical day-to-day practice, number of locally advanced and metastatic prostate cancers are rising. So we can start with the epidemiological study of prostate locally advanced and metastatic prostate cancer, etiology and metabolic evaluation of the stone disease, GUTB, penile cancer, and genetic study of genitourinary malignancies. So suppose two institutes wants to collaborate, then first we should have a group under the aegis of Urological Society of India, can be a urological research training group, which may include urologists, research scientists, and there should be a central database system. So from each institute, mentor, urology trainee, and data analyst can start a project, can discuss a project, and they have to submit the project under the urological research training group. And every monthly, the database should be updated, and every 3 monthly, it should be reported to the urological research training group. So this can be done if we have so many institutes. So this can be done between the two or more than two institutes. But the most important thing we need is a group under the aegis of Urological Society of India, which can monitor all those things. So to conclude, we should incorporate research training in curriculum. There should be separate research wing under the Urological Society of India. And there is an enthusiastic, interested, highly talented generation of urologists coming through training programs. And the role of mentor here is to encourage them to pursue their dreams and to provide them with rich soil that will allow them to become successful. Thank you.
Thank you, Manar. Thank you for highlighting the problems as well as providing with the solutions to start collaboration amongst the Indian urologists. Next, we have Dr. Shalabh Agarwal to talk on importance of balance between research and operative training. And may I ask him to share his slides, please?
Yeah, am I audible?
Yes.
Okay. Good evening, everyone. I am Dr. Shalabh Agarwal from KMC Mangalore. I would like to thank USI for giving me this opportunity to speak in this national forum. Today, my topic is importance of balance between research and operative training in residency. The most important medical advances often come from the physicians who ask why. In the year 1970, a 58-year-old man reported that he was fully potent within a year of radical prostatectomy. A young surgeon, Patrick Walsh, asked the question, why? But he did not stop there. He went back to the dissection hall, did the dissection on the cadaver, and determined the pelvic nerve anatomy. He returned to the anatomic operating room with the new knowledge and changed the radical prostatectomy forever. Clinical research is a vital component of residency training program. Currently, 3-year program for resident includes inpatient care. He has to perform operating room duties, emergencies calls, and he has to prepare for exams. So where is the time for research? The best residents are usually the best researchers. The reputation of the institution in scientific circle is best determined by the publications which came from the institutions. According to a Medline search on 15 March 2008, in the Journal of Urology, BJU, and Urology in the last 3 years, the number of publications from India were 82. However, the number of presentation in the same 3 years from US was 3,275. This depressing performance should help us and should motivate us to come back with the vengeance. What are the benefits of resident research? It helps us to promote evidence-based medicine. It provides the quality patient care. It helps the resident to develop the skills for lifelong learning. It enhances the analytical skills, develops the critical thinking. Since it is the era of fellowship, it is the prerequisite for most of the competitive fellowships. It has also been found that the resident who performs the research have the highest satisfaction rates compared to their peers. According to a paper, the various motivational factors for research are advanced career opportunities, intellectual changes, contribution to the medical progress, helping patients, and gratification of research. It has been found that in this researchers, around 71% of the researchers were dissatisfied with the research environment. So what is the research reason for dissatisfaction among the researchers? It was doing research in the spare time, lack of guidance, lack of equipment or manpower, bureaucratic hurdles, and prolongation of their time in the residency. What are the barriers to the research during residency? It can be insufficient interest of the resident, limited resident time, limited faculty time, paucity of the mentor, lack of resident research skills, absence of the research curriculum, and inadequate funding. So, how to overcome these obstacles? Stimulating interest. The transformation of the program culture in the institution is required. The resident should be challenged to critique the literature frequently. Morning rounds and all the reports should be based on the evidence-based medicine. General clubs should be organized frequently in the hospital. And the resident who accomplished some publication, his accomplishment should be publicized so that the other residents should take notice of that and are inspired to do the same. How to find resident time? The potential bottlenecks should be identified. The research question should be identified. A help of the research manager or project manager should be taken. Data collection should be facilitated, and the resident should be assisted with the statistical analysis. Temporary relieving the residents. In the US, there is in most of the urology training program, there is a dedicated 1 year for the research program. But in India, in the 3 years, we don't have such research years. So the resident can be given elective or rotation posting for 1 or 3 months, or in the same elective posting, he can be given a separate protected time for the research. Finding mentors. The good mentorship is crucial to the successful research. Best mentor should be matched to the most motivated resident. However, if no local mentors are available, then a research director should be appointed and further faculty development should be promoted. How to find the faculty time? A faculty is busy with other responsibilities also. Most of the faculties do the research in their personal time, but working with the resident can allow the faculty to explore their areas of interest. The faculty which participates in the research should be rewarded by the departmental chairs. Research curriculum should be developed in the hospital. However, if no research curriculum is available, online research training should be given. The research in progress meeting should be actively organized. This will lead to the development of the research culture in the hospital. Finally, the research follow the apprenticeship model, in which most of the research help is provided by the mentor. Finding funds. Funding is the most difficult part for doing the research. However, meta-analysis, chart reviews, or surveys does not require or requires a very little funding. The various sources of funding are in USA, National Institute of Health or Hospital Fund. In India, as told by my colleague Manar Singh, it is ISMR, Department of Science and Technology. The other sources can be internal grant and philanthropy. To conclude, resident research should be a requirement for all urology residents. An educational program with a research curriculum is needed for all residents. Research will help us to critically appraise the urological literature. It will help us to develop and practice the evidence-based medicine. Research is required to ensure the urology progresses and bring the novel techniques to the patients. I would like to finish my presentation by saying we are always one generation from ignorance and two from obsolescence. Thank you.
Thank you, Dr. Shalom. That was very enlightening. Next, we have Dr. Aditya Parikh from MPUH Nadyad talking on future of online training in the post-COVID era.
Okay, am I visible and are
Yes.
my slides, am I audible?
Yes.
All right. A very good evening to all of you. I'm Dr. Aditya Parikh from MPUH Nadyad. I'd like to thank USI and Dr. Milap for this opportunity and considering me worthy of speaking in the residence program. What I'm going to be speaking on is about an act that we are currently performing, online learning, and we'll be discussing its future in the post-COVID era. So while online learning has been around for quite some time and we've all benefited from it, there has been a bullish rise in stock since the rise of the COVID pandemic. A desire for continuing our academic pursuit while being safely seated in our homes has led us to leave behind our auditoriums and of course our banquet halls and bring education online to our homes in our couches and chairs. There is good evidence in literature to support that online training with its limitations is extremely useful. But what when we're able to roll back the clock? What when the undeniable but unforeseeable resolution of the COVID pandemic happens? Online training has made education an even more level playing field than it was before. Even if you had a bad day, as you can see in the GIF over there, during your NEET SS exam, you now have the opportunity of learning from the very best urology teachers in the country via the multiple webinars and masterclasses that happen online. The overheads, such as cost of travel and stay in various hotels while we travel, leaves from the workplace are no longer barriers to obtaining the highest quality of medical education that we seek. However, the world around us keeps going while we try to learn online. Distractions are plenty, as one can see in this video, and there is a large fear of missing out, a millennial concept called FOMO, because of the number of webinars that happen. We always feel like we could have or should have attended a webinar, but we could not because the real world around us was going on. Of course, too much of a good thing is good for nothing. Too many webinars have led to a slight dilution in content and of course, made it impossible for us to attend all of these webinars. We need an IMDb sort of module for various webinars that go around to tell us which webinar we should attend or which webinar we can let go of. One may not necessarily be very attentive during a webinar because during teaching online, where there is a lack of feedback, and of course, while learning, there is a lack of eyes on you, people can get away, as one can see in this video, with putting their poster and not at all attending the webinar. Saint Augustine said that the world is a book and those who don't travel read only one chapter. So when we are able to travel, we will want to travel and read the book of the world beyond our Campbell. Physical meetings were great stress busters. They gave us an opportunity to build camaraderie between colleagues and friends and interact with seniors, which know no parallel in the online milieu. I would like to now quote Dr. H.S. Bhatt, one of the founding fathers of urology in the country, who said very famously that great teachers are not those who dole out facts from a textbook, but those who pass their enthusiasm to those assigned to them for training and help them develop on their ideas further. The question is whether in the online milieu, one is able to inspire or get inspired. Some thoughts for the future. Virtual reality has tremendous potential to enhance online learning. One can get the feeling of speaking to a packed audience or learning while being seated in an auditorium full of people because of the virtual reality modules that are coming up and being added to various webinar forums. One could watch a virtuoso operating in a far corner of the world as if one is in that operation theater himself. It has made training and teaching of surgery easier than ever before. Eventually, it will come down to the tie between an old world charm of the offline world and the convenience of the online world. One can differentiate it as if it is a difference between a family picnic and a family video call. Of course, we love our family picnics, but we cannot have them every day, whereas we can have our video calls day in, day out. The USI, like it is wonderfully doing, should continue various webinars and have a structured urology curriculum that can benefit the residents. Of course, we need our urology IMDb. Now, hoping that an effective vaccine, a safe vaccine will arrive soon, and we'll be able to go back to times when after a talk, somebody from the audience can come to you and tell you with a pat on your back, well done, boy. I'm Aditya Parikh signing off. Thank you.
Thank you, Aditya, for highlighting the pros and cons of online training. Next, we have Dr. Juhil Nanamati from Gangaram Hospital talking on importance of learning things outside the routine curriculum.
Yeah, is it visible? And am I audible?
You can see, yes, yes.
Okay. Good evening, everyone. I am Dr. Juhal Nanavati. I am a final year resident from Sir Gangaram Hospital, New Delhi. Thank you for allowing me to speak on this platform. I'll be speaking on the importance of learning things outside the curriculum. There is no doubt that surgical residency is a tough and a hectic job to deal with. Being at the bottom of the surgical food chain, the work of residents is often not just limited to treating patients. A recent survey, as one of the other colleagues pointed out, was carried out to assess the prevalence of burnout in surgical residents, and it showed that the burnout prevalence was more than 50% among all residents, with surgical residents being affected somewhat higher than the medical residents. Especially in developing Asian countries, the prevalence was much higher than in the European countries. Although urology is expected to be a relatively stress-free branch, about 40% urology residents were found to have a burnout in a recent survey. So as doctors, work is and has to be our worship. As we try to sail through the 3 years of our residency within the walls of the hospital, we often do not find time to contemplate that there is an enormous world outside that needs to be explored and enjoyed. Take for example, music. The harmony between music and medicine dates back to the ancient Greek times, where Apollo, the Greek god of healing, is seen playing a musical instrument called the lyre, which is similar to the present day violin. There are numerous studies showing the positive effects of music in stressful jobs. In fact, recently it has objectively shown to attenuate stress response by decreasing the levels of interleukin-6 and cortisol. Moreover, not just listening to music, but playing musical instruments has shown to improve hand-eye coordination as well as dexterity. Apart from music, residents can lay their hands on developing good photography skills. With modern day smartphones and cameras, anyone can click good pictures by just pointing and shooting. But learning the intricacies of various aspects of photography will be of immense help in proper documentation, publishing, educating our own patients as well as ourselves. As surgical residents, we are expected to show a certain degree of skill and dexterity in the operation theater. There are so many studies that have shown that surgeons who regularly play video games have higher level of skill compared to those who do not. Video games improve dexterity, fine motor skills, visual attention, as well as depth perception. After all, with the emergence of the surgical robot, are we all not in a certain way just playing video games in the OT? Similarly, with the hectic work schedules of residents, social life often takes a huge hit during residency. Social media is very much underutilized by residents. Today, platforms like Facebook, Twitter, and Instagram are great social media platforms, boasting of more than 3 billion users across the world. Social media can help is a great source of major news and emerging research. It is a great platform for dissemination of information about conferences and own experiences. It is also a platform for advocating a cause to larger audiences. For practicing surgeons, it is a great source of networking, crowdsourcing, and advertising. Another very important aspect to learn outside the curriculum is to understand the legal aspects of medicine. With the increasing consumer awareness and consequent rise in medical litigations, there is a need for every health professional to be alert and medico-legally aware. As doctors, we are among the most noble and respected professionals in the society. So, an important part of being a well-rounded clinician is not only knowing the clinical aspects of things, but also having a sense of responsibility towards the well-being of the society as a whole. Last but not the least, empathy is something no curriculum will teach us. I would like to end with one of the most read articles in New England Journal of Medicine in 2018 at the time when it was published. It is about a first-year resident who, during his daily rounds with his consultant, presented a case of a patient he admitted for chest pain after walking his dog last evening. The resident was very proud that he had managed the patient well and was expecting a lot of appreciation from the consultant. But then the only question his consultant asked him on that round was, what was the name of the patient's dog? And the resident was stunned. He not only did not know the dog's name, but was confused as to how the dog's name was relevant. The consultant then walked to the patient, asked him his dog's name, and had a short talk with the patient to make him at ease. The author of this article writes that 4 years later, he was not sure anything he has learned from residency has been more useful than that single question. He says that this small incident led to a transformation of how he looked at his residency, realizing that there was an actual person behind that hospital issued gown. It is very easy to lose sight of ourselves during residency, but if there is one metaphorical message that can be taken from this anecdote, it is that always make sure you get the name of the dog. Thank you.
Thank you, Jewel. That was simply brilliant. I think it was one of the toughest talks of today's webinar, and you have just presented it with so much ease. Next, we have Dr. Sitaram from KMC Manipal. He's one of the nicest orators I've come across. He'll be talking on role of simulation training in neurology residency program.
Good evening, everyone. Can you see my screen?
Yes, Sitaram, we can see.
Yeah, thank you, Milab, for that introduction. I thank USI, ISU for giving me this opportunity. And my today's talk is role of simulation in urology residency program, need or luxury. Just a second, please. Yes. So I know my presentation is the last presentation, and I would like to take it little lightly. And I'm lucky that my presentation is the last presentation, because looking at the previous presentations, I'm pretty sure I'm not up to that mark. And I realized that my previous presentation don't have empathy for the last student in the class. So coming to the presentation, I have no disclosures. So to put it simply, what is simulation? Simulation is an imitation of a situation or process in an artificial environment as near as possible to a real life situation. So it was initially demonstrated by Sushruta way back in the past, where he demonstrated simulation over cadavers and vegetables. But it's in 1960 when a girl drowned in the river of Seine in Paris, and no one there can resuscitate her because nobody is prepared for that. Nobody knows how to resuscitate. That's when the modern day resuscitation mannequin that we all have seen, the Rescue Anne, was developed, and that's the first modern day simulator. So why simulation? Patient safety is the cornerstone of our medical profession, and that's where the simulation plays its role. The traditional way of teaching is the Halcyon way, that is, see one, do one, and teach one. But with the rising advanced trends of minimally invasive techniques and the rising ethical considerations, legal considerations, and the decreasing hands-on exposure to the residents, the Halcyon way may need a little change in that. And all the residents need to pass through the matrix of learning. That is the imitation. We see our seniors, we see our staff, and we try to imitate them. And then we try it on a patient. We try to manipulate, means we perform and then we realize our errors, and then we try to refine ourselves, and we commit little less errors, but we still commit errors, and that we are committing on a live patient. And then we go for the articulation, ability to multitask. And then finally, naturalization, that is high level of performance of autopilot mode. So the initial error-prone learning curve is what that's the most problematic part, because the simulation can help to shift that error-prone learning curve from the operation theater to a place which is safe and which is a peace environment where we can all learn well and decrease the errors that we commit. So role of simulation. Simulation not only helps for learning, it helps for practice and it helps for the advancement. A simulation can give us a good idea about the anatomy of the structures, what we are going to deal. It gives a whole understanding of the process. It gives a whole understanding of instruments and the steps associated with the surgery. I was very excited to do a TURP in the initial parts of my residency. I read everything. I went into theater and then realized that instruments of TURP are so much that my mind can't comprehend. But I was a pretty fast learner. So in half an hour of anesthesia time, I just figured out how to arrange instruments. And after half an hour, I tried to vent in, then realized I can't negotiate a 26 French rectoscope. And I had to use a Otis urethrodome, which is out of syllabus. So then I was thrown out of theater. That's a different scenario. So simulation will help us to have an assessment beforehand, to have an idea of the instruments, what are there for the procedure, to understand, to learn beforehand. And then it is a safe, well-controlled environment. And you can do n number of limitless repetitions, whatever you want to do, how many times you want to do. The same step, if you want, you can do it multiple times. You can know your lags and you can train well. So it trains the spinal component of a surgeon so that it makes the young surgeon adept at dealing with real-life intraoperative situations in a better and less stressful manner. It helps shorten the learning curve by enabling the repetitions and revisions. It's not just the technical skills that are important in simulation, but also the non-technical skills. That means our communication, teamwork, leadership abilities, decision making, planning, and situational awareness all will be improved with simulation. Evidence is fairly positive for the simulation results. Studies show that the trainees who had simulation beforehand had decreased surgical times, decreased complication rates, the confidence of the surgeons is better, and the overall patient outcome is better. Simulation is finding its route into the medical curriculum all over the world. In UK, there is a nationwide simulation program called Simulate, where it is validated and is incorporated into the curriculum. In Denmark, it is now a rule that all the vascular surgeons should pass a simulation surgery exam to get their degrees. So what are the simulators in urology? There are mechanical simulators, virtual reality simulators, hybrid human cadavers, and animal models. But each have their own advantages and disadvantages. Like human cadavers and animal models are having many ethical issues. To get them hands-on is very difficult. The virtual reality and hybrid simulators are per se very costly to start with. And then the mechanical simulators, which are low fidelity simulators. So what to look for in a simulator? The thing we have to look for in a simulator is reliability and validity. It should be consistent with the results and it should be accurate. Validity can be subdivided as face validity, content, construct, and predictive. So if a simulator is given for a resident, it is included in the institute, then the simulator should have the content that is uh, relevant to the trainee and the trainer. It should encompass all the instruments that are relevant to the steps, relevant to the procedure that it promised to deliver. And it should be able to measure the skills and the abilities of the trainee and accurately tell us about the outcomes. So in urology, all the residents dream of doing a good TUR, PPCNL, which are the basic bread and butter for all the urologists. So there are some validated high fidelity simulators available in the market, like TURP VR simulator by Symbionics, TURP simulator Melerit, green light simulators from photoselective evaporation of the prostate, to name few. And then Perk Mentor for PCNL and MIST nephrectomy simulator for nephrectomies. So all these high fidelity simulators are really good. Like you can perform all the procedure, the entire procedure from step 1 to the end. You can proceed and you can divide the steps. You can understand where you are lagging, and you can even increase the difficulty level for each individual step and try again and again. And you can get even a report card at the end where you are lagging behind. But what's the issue with this? Issue with this is cost. High fidelity simulators are definitely very, very costly, and having a high fidelity simulator is nothing less than a luxury. But then, what is the cost of a complication? What is the cost of a life? What is the cost of a trainee's confidence? So, simply saying a simulator is costly and not having a curriculum is not the solution. We should find a solution for that. So the solutions are to find a low cost instrument, low cost simulator with high fidelity, means with more naturalism associated with that. So this is a paper published from Nadiad. They have used a bovine kidney, placed it in a chicken carcass, and then instilled the contrast. They practiced PCNL punctures over this, and they compared with even with the manicure models, and they realized that this improves the feel, the tissue feel for the residents, and it helps in more accuracy and tissue feel. This is even validated and is in the availability. So coming to another paper produced by Dr. Venkatesh sir, they used a bottle guard, which is a representative of the posterior abdominal wall for training of punctures in PCNL. And the paper shows very pretty good results. And I changed my opinion regarding bottle guard after seeing this paper. And the other ones that we know very familiar with are Dr. Ashish Ravandale's fluoroless PCNL puncture approaches. This we have commonly seen in Euromet and the USI conferences. It simply uses a white sheet and a white paper and a light, and you can try n number of times. But the only thing is you have to change the white paper, because I tried from the same sheet and then I realized I was 100% right, because I'm going through the same hole that my seniors has made. So, and then there are multiple trainers in the TURP, like the resection trainer, Bristol TURP simulator, Ravandale's TURP simulators. So these simulators can help us to how to deal with the instrument, how the receptoscope should move, how to evacuate the chips, how to control the bleeding, what irrigation fluid to use, and what are the anatomical landmarks. All this can be demonstrated or understood from these simulators. Similarly, low fidelity lab trainers will help us with 3D orientation, hand-on-eye coordination, depth perception, and ergonomic considerations. So what are the principles of simulation training? Simulation training doesn't simply mean buy a simulator and tell the trainee to practice over it. It doesn't work like that. It should be incorporated into the curriculum vigorously. Both the trainee and the trainer should be involved in the learning process. There should be set target of goal which a trainee should achieve over his curriculum. It should start with the early easy methods and should go towards the high fidelity systems with higher difficulty level of tasks. So there should be repeated exposure over a prolonged period of time. There should be good feedback on the performance of the residents. And then coming to the finally the simulation fidelity. We all know that fidelity, which is realism, which means realism, is important. But then we all know the surgical knots and how we practice. It is nothing but simulation. We tried it over and over to a surgical table, and we know how important and impactful it is. It will obviously save our scrubs from dropping down. So there are national level platforms like Euromet and USI. These prepare a platform or a pooling place where many residents can come together. They learn multiple techniques on simulators, and these are the places where, if possible, we can put a high fidelity simulator, and students can have better, more experience. But because of the COVID, I couldn't go in my final year of residency in this. I hope they conduct virtual simulation. And coming to the cons, lack of tissue resistance and tactile sensation is one problem, and simulators don't bleed, at least the low fidelity ones, and the positive for cheap and high fidelity models. To conclude, simulation enhances clinical competence, enables easier amalgamation of both technical and non-technical skills. But one should realize that simulation is an adjunct rather than replacement of clinical training. So see one, simulate many, do one, teach one. Thank you.
Thank you, Sitaram. As usual, you are flawless. That concludes the second session. Now, can I have Dr. Shravan Singh sir and Sujata ma'am with their expert comments?
Right. I think on the outset, I would like to again congratulate all of you being so perfect. I can say that very precise to the time. See, it was 7:40 going to click and the program is over. Second session, in spite of the fact, but I thought I am interfering by taking 1 minute time in between when the first session was over. So just, I am telling you, I was overwhelmed as a teacher, as a mentor. I'm very happy. Just to be a teacher and mentor doesn't mean that you are a teacher and mentor only for your own career. I take in that perspective. Yes, I'm a teacher for the whole country, for the whole world. I'm a mentor for the whole country, for the whole world. So in that perspective, again, I am telling you, I'm not exaggerating. I'm just telling you the fact. All of you have done marvelous job. All this has been possible because you have a personality to accept the challenge. You have put all effort because you have a firm determination. You were determined to prepare your talk very excellent way. And then you have persevered. And today I can see the result. I am overwhelmed. As a teacher, just all of you have done excellent job. I have nothing to add. Only thing, because just for the sake of being expert, being called expert, and you have made me just to talk something, I have to talk something. Now, how the research is helpful. Yes, I do say the candidate, my resident, whoever I meet, it makes you perfect because you are a critical thinking, as had been told by Dr. Salam Agarwal. It makes you very critical. Thinking critical when you are doing surgery is a way, how do you think at the point? How much precise are you? Because that's called research. So everywhere you do conduct research, only that should come into form of publication. I could see one of you are telling there have been only 80 publications in general nephrology and British nephrology in last 3 years from India. It could have been more. We are publishing our article in less impact journals, so it should have good impact. So regarding the first talk, which was again, Manar Singh has very nicely he has presented the way how the study should be conducted and how the collaboration can be established. It is possible, yes. The answer is yes, it is possible. Observational study can be conducted. Again, at the same time, what he has told, that there is a need for that, but at the same time, there's a limitation. What is the limitation is the attitude of the people, mentor from all the institute, the HOD from all the institute, they can take the resident for collaborative research. He has again told the limitation. But again, by collaboration, you can make use of optimal use of time, optimal use of cases, so that you have a large data available with you. You can use optimal use of resources available at one center, others can also use it. And you have optimal use of manpower. Means statistician may be available one center, other center. So that is the real benefit of collaborative research. The country is well known and it makes you develop a team spirit. That's called collaboration. But just for the sake of telling you the funding agency in India, government funding agency where we have been getting again funding is DVT, CSIR, ICMR, DST, which is now called CERV, and University Grant Commission. And there are other private funding agencies where you can get the fund. And our USI certainly will look forward for providing you funds for that. Yes, but many research work doesn't require any fund. Now, regarding the research, as I have told you, yes, the clinical practice, it makes you think of every step to become, because idea is important in every area, whether it's a surgical technique. If you do conduct a research, you have a research mind person because you are thinking of something. And during surgery, now you can innovate some technique also. You can find out some ways. And then what I will say that during residency, you have got limited time, but still it is possible that you have basic knowledge of basic, again, concept of high quality research, your basic concept of being a good professional. So what makes you a good professional, that is the habit of your learning outside your curriculum. Now, if you are inside the curriculum, that makes you professional, but you have a habit of learning outside a professional, that makes you a very successful man in the human life. Because that you can learn everywhere. You have got the habit of learning. So develop the habit of learning. You can learn from outside the world, also outside the curriculum. And that's useful for your life. I think the rest of the point I will leave to Madam now, because I should not take time. You have been so particular, so pertinent, and so precise in everywhere. So I would not like to take much time. And certainly, again, I will just touch Dr. Sitaram. Sitaram, he talked about the simulation, that is useful because it makes you learn in a very unstressful situation. At least you have basic concept. Again, you will learn about what is going to do and how the things can be done outside without much stress. So again, he has highlighted the useful innovative technique again produce in India. So I'm very much again thankful to all of you. The online learning, again, pros and cons that we discussed. The excess of everything is bad. Yes, so how to strike balance, that again depends on all of us. So how to make online learning very useful, not making again stressful. And with that comment, again, I will hand it over to Madam, again, Sujata. Madam Sujata, I think don't feel deprived, but female has been earlier, and then finally what conclusion has to come from you, right? So never will feel deprived. Yes, we are here because you are the home ministry. Without ladies, the things cannot run. And I think we take the country is changing, the attitude is changing. And that's why I referred you. There is one program is called Tejaswini, where the people are discouraging sex discrimination. And they are encouraging ladies are on the top in many fields. And I know as a teacher, we always, again, we are proud of you. Madam, to you now.
Yeah. Thank you, sir, and thank you for your comments. Yeah, I just wanted to make her talk complete, and that was my view of my experience as a female surgeon, as a general surgeon, and then a urologist. So it doesn't have to apply to everybody. Anyway, your comments are more than welcome, and thank you. Now, regarding today's our topics which we had to discuss, I have only 2 or 3 comments to make. First was regarding the research within institutes, and I feel we are totally lacking there. And if at all various zones like West Zone, South Zone, East Zone, North Zone can do it individually, or USI as a society can do it, that we have so many aspects which are been not covered, and I think we are totally lagging behind. And I really admire the British and European countries in sharing their experience and doing collaborative research, and I think we need to take an inkling from them. Secondly, I agree with the speaker very much that the teachers also need to have some training in this aspect. And I think as institutional heads and even other participants from various institutes, we need to come together and find out and reframe our questions, which can add to the knowledge of people all over the world. So I would definitely like such an initiative being taken by USI. I would like to make a point about empathy, and I appreciate the talk given on it, and it was really eye-opening. And I think though as a teacher you cannot bring about empathy in anybody, but I think through your personal behavior, and this is one of my teaching which I tell on the first day to each and every student who joins my department, that there has to be no batting of patients, and each patient has to be treated as your own relative, and as you would treat your father, mother, or brother, the same attitude has to go towards treatment of patients. And if you do that, definitely you would turn out to be a very good human being and a very good urologist too. Regarding online teaching, yes, online teaching has played a very big impact in recent times, and I think we definitely benefited by so many experts and giving us so much of knowledge, and it was a very good feast for most of them. But I do miss the conferences. I do miss that pat which he mentioned on his back, and the personal contact. I hope the COVID gets soon over and we go back to our conferences and the post-conference activities too. And coming to the last talk by Sitaram on simulation, yeah, I do agree. Simulation gives you a lot of confidence in an environment where you are not pressurized by time and various people looking at you, and your boss standing behind you and observing what you are doing on the TV, on the the screen. So these all things are taken care of during simulation. But as mentioned in Love Belly, unless you go to the sea and unless you face the problems in a patient, you don't learn. So it is no comparison on virtual simulation and actual patient care and actual patient surgery on a patient has no comparison. And you have to go through that experience of burning your fingers, doing mistakes and getting out of them. And I feel that has a very big impact on you as a person and as a surgeon and as a urologist. And I also wanted to make one last comment. I don't know whether we have time, but I feel that this is a very good initiative by all the, and today's topics were totally out of the blue, and really you had to think what you would like to contribute and to talk to them. And I would like to congratulate all of the young urologists who have taken efforts in making their presentations and doing them very well. Thank you very much both to USI and all of you for giving this opportunity. That also validates the fact that you honor female urologists and you give them an opportunity every time.
Right, ma'am. Just to make the light good, because ma'am, we have been sitting here, but I didn't realize this is already 2.5 hours over. And
yeah,
that's a good way. So I'm very happy to see that candidates or residents again progressing and achieving. And the USI, the president, secretary, board, again, ISU chairman, again, all of them are so supportive and encouraging.
yeah.
How they drafted it, how they thought of, really praiseworthy. What was the name of the dog? Yes, that was the very brilliant, again, writing in NEJM. Now, again, has been told by you that how to learn empathy. That was the message the teacher wanted to give to the resident. You should talk to the patient, not only he's suffering. You have to be very familiar with him. Is everything you have to learn. So as a teacher, I thought, let me put the remark also. So thank you very much, ma'am, and everybody. I'm very much overwhelmed, and I know I was so much talkative, I will not leave, but I am concluding my talk and again comment, and I am handing it over to again to Dr. Milab. To Dr. Milab.
Thank you, sir. Thank you, sir, and thank you, ma'am, for your wonderful words and
Dr.
opinions.
Rajiv, Milab, there is one question from the chat box you can take. This is from Dr. Philip. Before you finish, what is the real situation of research in institutions of MCH and DNB centers to the experts?
Yes. Yeah.
Dr. Shravan, so maybe yes, I will take it because both the questions I have seen.
What is the question? Can you repeat the question?
What is the real situation of research in the MCH and DNB?
Real situation.
Situation.
Real situation.
Yeah, so I have seen that. What is the real situation of research in institutions of both MCH and DNB center? Because I could see that, yeah, the research was were the two of the topic. How to again, can you learn anything from research at the time of residency? So again, I think residency is not only for making you, residency in urology is not just to make you surgeon. You should be again a researcher also. You should be a researcher also. A researcher, again, when you are a researcher, you learn many things by critical analysis. So now the situation Dr. Philip Raj is asking, the situation of research. Yes, we have again dissertation. At institution, we have dissertation at our institute. And certainly that is, again, during that time, we do see how to involve them in laboratory, how to make the resident again, make a protocol themselves. And then if they can take other additional research because we have got funding, so we do involve them in those research activity. So that makes again, they are again contributing as a part of the.
Dr. Rajiv?
Yes.
Dr. Rajiv? Dr. Rajiv?
Thank you, Dr. Milla, for a wonderful webinar. I could say that it was an excellent webinar. As Professor S.K. Singh has commented, we were glued to the laptop throughout. And it is a fact that how 2 hours plus have passed out in such a quick time, we didn't know. And one fact that I really thank all the speakers for presenting their topic wonderfully, and moreover, I think they have shown a thing to the seniors that how to stick to the time. All the speakers were crisp to the time, and in fact, the webinar concluded 4 minutes before the scheduled time. And all presented very well. And in each talk, one thing I showed that there was a take-home message. That is the main thing, and it was a really an eye opener in some areas to many of us. And this shows actually this was planned because we wanted to know what the residents want, what they think about the MCH, what they think about the DNB, how they choose their thing when they got selected for MCH DNB, what is lacking where, and what is the need of the hour, and what in their mind, what is the future training to be. And this was the one when I discussed with Milap what I wanted this program to be, and it should be something out of the box. And they really made this webinar something out of the box. And I really thank Milap and all the speakers for contributing very well and excellent presentation. And once again, I thank on behalf of USI and ISU, all of them, and even the experts for putting their viewpoints and giving us more ideas and the thing. And regarding 2 points which was highlighted regarding the collaborative research and simulation, we had a lot of plans for this collaborative research and simulation. In fact, simulation urology has come a long way from since it started around 5 years back. And I think across the globe, Urological Society of India is standing at #1 regarding simulation and the cadaver training programs, wet and dry lab. And we had scheduled more wet lab programs and other things because of the pandemic. We couldn't take up, and the collaborative research and standard curriculum all were in the line. It is worked out, and no doubt in the years to come, urology will be handling everything in a much better way. Everything will be there. And this question was put to me by one of the speakers about the collaborative research, and I have given my thought views to that speaker when he, few days back, when he posted this question to me about collaborative research in Indian institutions. Anyway, really thank all everyone for making this webinar a success. Only my sad part was that we have around 387 DNB plus MCH trainees. At least at the moment, there are 285 minus, this is minus those have passed out. But today only 119 participants. And all these talks were prepared well. And all the residents should have listened to this, and they should have cleared their viewpoints by putting various questions to the expert panelists. And even when I chose the experts, I had people in mind who can answer to all their doubts. But it is a sad point that some of the 50% of the residents has totally ignored this webinar. Even the urology has started the USI Resident Smart Learning Program. A lot of efforts have been put into to make it possible and go as scheduled throughout the thing, but the participation from the residents are quite lacking. I want all of you to come forward, and it is for you, and we have been struggling, and USI is one of the societies across the globe which is having regular virtual classes for the residents. I say some weeks we have 2 classes, but average 1 class per week. And most of the faculties are prominent teachers and examiners for MCH and DNB. I want the residents to take these virtual classes seriously. Thank you all once again. And I thank on behalf of USI and ISU, the Sun Pharma team, as well as the central office USI, for all the logistic support they have been giving us for the success of these programs. Thank you all once again. Good night.
Good night, sir. Thank you, sir.
Thank you, sir.
Good night. Good night.
Good night.
Happy congratulations to all of you. I think we wish that other regions would have got inspiration from all of you. Well done, all my boys. All my best wishes to you for your future.
Thank you.
Bye. Bye. Good night, Dr. Rajiv. Goodbye, Dr. Rajiv. Thank you, sir.
Thank you, everybody. And one thing is very clear, as Dr. Rajiv TP has mentioned, that many of the residents, almost 50% of the residents are not joining various programs. For that, we are planning one program for the faculty, so that the faculty can motivate their residents, because there is a need to educate faculty now after residents. And one program for faculty training, as in Euromat, we are already integrated training of trainers, and that is must. And I'm in discussion with Dr. Arun Chawla and Dr. Rajiv TP, and in the next year, when we start our simulations again, this is a good news that in Euromet program, I had a discussion already, and capsule program at smaller scale we are going to start immediately with the start of the new year. So that is one. And the second, now the faculty training program is the next need, and that will complete our all the efforts of training and the purpose of Indian School of Urology.
Thank you, Dr. Ajib. Thank you very much. Being a good leader, but just I thought of sharing with you my sad news. By 4 o'clock, I thought I may not be able to join you because I will be arrived. I have lost my one of the closest friend at Punjab University, whom I know for the last 34 years. And I have just Turnal Films was over by 4 o'clock. But because last time I have not been there. So, but I'm telling you, thank you all of you, because I remain attached with all of you. And thank you very much for all the support, because I got all of you with me, and I got involved too much with you, and I forgot that I had lost my friend yesterday, and today I have got him. Thank you very much. Have a good.
Very sorry to note that, sir.
Very sorry to hear that. I kept the courage and get remain involved with all of you. I thought I should not make you impassionate about my emotion. Rather, I thought of forgetting, and I forgot with you, because you are another family. All of you are my family. And I am so much proud of you that you kept me involved throughout. And I remain, again, glued to the talk of the resident, glued to the talk of the leaders, and glued to the screen. Thank you very much for, again, keeping me with you, and again, taking my share of sorrow. Thank you very much.
Thank you, sir.
Rajiv, can I ask you one thing? I mean, this was an excellent webinar with a quality of presentations. That is, I think Corona has shown something. A good part of positive side of Corona is to attend the many virtual the seminars, webinars, and the fantastic orators, and they have picked it up. Those who are keen actually picked it up from there. That's the quality of presentation is so high. It's a pity that a lot of people didn't connect. But is it possible just with the advertisement, just rerun the show? If you know,
teacher should have told, sir. Teacher, all teacher.
I know.
Because as a teacher, I send it, sir, by again today. But at the same time, yesterday I got disturbed. I was thinking a whole day I remained involved with my families. And today up to 4 o'clock, I was occupied. By 4 o'clock, I have sent the message to the resident, but then see, I didn't cross-check how many of them have joined. But again, onus falls on all of us. You could have spread it. We could have spread it, because everything, we should not leave it to the secretary and to the chairman of ISU only. They also need help from us, and we are a party to that, sir. So that I thought, let us be responsible and let us spread, and message is very clear from the chairman of ISU. I think we should make them, again, that's why he is thinking of training the teachers also for, again, how to make use of ourselves. Yes.
Yeah. Oh, okay. Give it a thought. So this is an exclusive one. If you can just rerun the show recorded thing with an advertisement, it will be good for everybody.
Advertisement, I have advertised in all.
No. You have not done any. You have done everything.
All WhatsApps. He's shown
everything done.
Everywhere he has seen.
Everything done. But I mean,
I know.
I'll only add one thing.
Dr. Rajiv.
Sir is suggesting something. Dr. Chawla, Dr. Shivaji sir is suggesting something.
No, that's fine. What I said, you didn't turn any stone unturned. What I'm saying, those people have, for the Sunday and all those things, have missed this exclusive one, and it turned out so well. I mean, you don't have to make a virtual thing. If it's a recorded thing, Sun can organize and advertise and then put it back again.
No, 7 of my regents have joined, sir. 7 of my regents have joined.
Just a thought, actually. Think
Dr.
about
Rajiv, can I make here just add to what Dr. Shivaji is telling? I think it is like a same journey when we are talking about these programs meant for the residents. Now, if you see the whole program, it is just so nicely made and carved out for the residents to motivate and promote them. But what we see in actual scenario is we have to see there should be out of 397 or 400, at least 20 to 25% should come out who should be committed to these type of webinars. They want to take it forward. Yeah. What we see in abroad is in abroad, the difference is a urology resident before residency is already into some epidemiology, is in MPH, and they are much better placed to do independent research. Here in India, if a resident has to do research, he has to be under the guide, and whatever collaborative research we are talking, residents mean a student. He is not a permanent employee of the institution. Data and everything belongs to the hospital or institution. So it's very difficult. There are so many bottlenecks. Added to that is the so many funny rules of the ethical committee, which brings almost the motivation level to zero for all the residents. So there has to be total change in the approach of all the agencies which promote research. Now, the way NMC is starting from MBBS onwards, I think the culture, everything has to go from the beginning, MBBS first prof. Then only 20 or 10 years down the line, we'll see the drastic changes. Otherwise, we are far, far behind the Western countries and the neighboring countries also in this area. So the residents, those who spoke now, they should adhere or somehow try to have some percentage who stick to these type of research, either clinical or basic, and continue this area and just keep sowing the seeds so that later on we have the fruits. But at this point, all these things live fairly in the form of webinars only. So we need to have a little very, very different and practical approach from various sectors, all which are connected to this type of research, whether it's education or clinical research. That's the way I think.
Thank you. So we will look forward some modification and changes, and we will see. And regarding Shivaji Basu's request, yes, we will do. And this is one of the best webinars we had, which was some issues, different issues we have sorted out of the box issues. Anyway, all the webinars are posted on USI TV, and this will also be available on USI TV after 2 days. So whatever webinars we had, all are archived on USI TV.
One thing I'll add at the end that in my department as experiment in our logbook where we are doing various activities, the whole calendar is integrated, and we are marking attendance. We are marking not only the attendance of the residents and but the faculty also. And what has happened initially that 90% of them were absent, and now they know that they are watched, and after that they are coming, and now they are getting interested, and now they are asking that what is the next webinar. So you have to make them understand that these are very, very useful. This is the need of the time, and this is also going to change the whole scenario in our education, and that day is not far. That as we are leading today, the urology should keep on leading compared to other specialties, and we should show the other specialties how to adopt this change scenario and change way of education. And Dr. S.K. Singh was absolutely right, and in understanding and in sharing that how all the teachers are to be involved. I'll give you very small, when we are talking about research, I have been in USI council meetings so many times, and Dr. S.K. Singh was also there. And we have seen that we had to dissolve the research cell 3 times because the chairman told I was not able to do anything. So who is to be educated first is our own members and the teachers also. That is very important, and very, very good is that now the cell-based functioning of USI, which has started 3 years back. The research and basic sciences, that has become the now very important otherwise also, and we are understanding the importance, and it is the endeavor of Indian School of Urology under the aegis of Urology Society of India. And I salute Dr. Rajiv TP and also Dr. Arun Chawla for their passion. And these 3-4 years have changed the whole scenario. You all are appreciating, and COVID is bad. We have lost many friends, many colleagues. Last week, we lost our head of the Department of Hepatology in my hospital, and we are very, very sad. But this has given us something that online we are meeting, and we are interacting, and the things are changing, and let us hope the future is ours. Thank you.
And I also echo Arun Chawla's comments that for the priming the urology DNB and MCA, they are in UK and USA. That in MBBS you have to present 3 projects. So you get a habit of research work and present the project, which is not seen in our country. And Rajiv Sudhi, you're in the policy making Indian scenario. So you should start looking into it, so that the people are straight. Oh, lovely. Thank you very much. That was a wonderful thing, Rajiv.
Thank you, sir.
Good night, all of you.
I think though the residents who were not present, they missed. It was a wonderful and very exciting. I think there will be many who will log on to the USI archives to see it many times.
Sure,
I'm very sure.
Sure, very nice. Yeah, I agree. But yes, congratulations to all of you.
Well covered, and that to the point. That's the main thing.
Very nice.
Now that the time has come with that webinar after webinar, we are telling that this was the best. And till today, I appreciated and liked this webinar the most. I have told this 2-3 times before.
Absolutely.
That's I'm telling you again, to young people, just to tell what to do. You have not to say how to do. They will do it in a wonderful way. And that's I think they have given the example. Thank you very much. And good night to all of you, sir.
Bye.
And yeah, we are very much proud of them, all of them. Thank you very much, sir. Yeah. Bye. Bye. Good night, sir. Good night.
Thank you.